Today's topic is appendix, very important topic. Everybody must know what is appendix, what is appendicitis, what are the complications of appendicitis, what are the complications of appendicectomy. So, very important topic. Everybody must know. Normal appendix, picture showing normal appendix. Surgical anatomy of appendix. Location, it is the terminal end of cecum where three tinea join about 2 centimeter below the ileocecal orifice. Size of appendix is 5 to 10 centimeter. Diameter 3 to 8 millimeter diameter of lumen. It is 1 to 3 millimeter. Diameter of lumen is 1 to 3 millimeter with matchsticks. So it is terminal end of cecum where three tinea coli join. We say all road lead to Rome. सभी जो रोड है वो रोम को जाके मिलते हैं. Like that, all three tinea coli join at the end of where appendix start. About 2 centimeter, it is present 2 centimeter below the ileocecal orifice. Size of appendix is 5 to 10 centimeter. Length, diameter 3 to 8 millimeter in diameter, and lumen is 1 to 3 millimeter in lumen. It is matchsticks diameter. Mesoappendix, it is the extension of mesentery, contain appendicular artery, a branch of ileocecal artery. It is the end artery. Often an accessory appendicular artery may be present. Thrombosis of these vessels lead to gangrenous appendicitis. We have seen many times gangrenous appendicitis due to thrombus of appendicular artery. Appendicular artery is the end artery, so thrombosis occur and gangrene of the appendix occur often. This picture showing appendix, appendicular artery. This is inferior division of ileocecal artery showing ileal branch, posterior cecal branch, ascending branch, anterior cecal artery, and then appendicular artery. It's very important. Duplication of appendix. Type A, partial duplication in a single cecum. Type B, two separate appendix in a single cecum. Type C, double cecum with each appendix. So there are three types of duplication. This picture showing type A, type B, and type C. Type A, bird beak appendix. Type B, single cecum double appendix. Type C, double cecum double appendix. Position of appendix, most common is the uterocecal. It is present behind the cecum. Next common is pelvic, 21%. Retrocecal is a 75%. Pelvic, 21%. Other sides are periileal, they are 1%. Postileal, paracecal, subcecal, and subhepatic, 2%. Very important. We must know various position of appendix. So retrocecal is very common. Next to the pelvic. This picture showing different position of appendix. This periileal, postileal, pelvic, subcecal, retrocecal, and paracecal. Now come on the etiology. It is also very important. It is common in young males. It is common in white race. Diet increased chances of appendicitis in non-vegetarian. It is common in May and August. Seasonal variation, often called epidemic appendicitis. Viral infection is common cause of appendicitis. Family history, appendicitis in children with appendicitis occurring in first degree relatives is very common. Obstruction of lumen causing obstructive appendicitis, like E. coli can obstruct lumen of the appendix. Stricture also can cause obstructive appendicitis. Foreign body, round worm or thread worm can obstruct lumen of the appendix and can cause appendicitis. Adhesions and kinking can also cause appendicitis. Carcinoma cecum near base, ileocecal Crohn's disease may also cause appendicitis. Distal colonic obstruction can also cause acute appendicitis. Abuse of purgative also may cause appendicitis. Now come on the organism. There are various organisms involved in appendicitis, but most common is E. coli 85% and streptococci. Enterococci 30%, streptococci, Clostridium walchi and bacteria may also can cause appendicitis. Pseudoappendicitis due to acute ileitis following Yersinia infection can cause pseudoappendicitis. It is often due to Crohn's disease. Now come on the pathology of appendicitis. Lymphatic hyperplasia causes luminal obstruction. Luminal obstruction increase intraluminal pressure, edema, mucosal ulceration, increased intraluminal pressure, increase edema and mucosal ulceration. Mucosal ulceration and edema increase bacterial translocation to submucosa. It cause maybe resolve or it is further causes venous obstruction. Venous obstruction causes ischemia of appendix wall. Ischemia of appendix wall causes invasion of muscularis propria. Submucosa causes acute appendicitis. It may convert into the lump or mucosal, or it may be gangrenous appendicitis, which causes peritonitis. So this is the pathology of appendicitis. It's very important. Everybody must know pathology of appendicitis. Once again, I repeat, lymphatic hyperplasia lead to luminal obstruction, lead to increased intraluminal pressure, lead to edema and mucosal ulceration, which cause bacterial translocation to submucosa. It may resolve or may further cause venous obstruction. Venous obstruction may lead to ischemia of appendicular wall, may lead to invasion of muscular propria, submucosa, cause acute appendicitis. It may form lump or cause mucosal, or it may be gangrenous, and gangrenous appendicitis cause peritonitis, or it can be perforate. So pathogenesis: acute inflammation of mucous membrane with secondary infection without obstruction cause acute non-obstructive appendicitis. So acute inflammation of mucous membrane with secondary infection without obstruction cause acute non-obstructive appendicitis. Luminal obstruction by Fecoli or lymphoid hyperplasia pinworm cause uh, if venous obstruction or collect inside the lumen, increase intraluminal pressure, leads to blocked lymphatic and venous drainage, resulting in increased edema of mucosal wall, cause mucosal ulceration and ischemia, bacterial translocation, bacterial spread through submucosa and mucosal propria, muscularis propria, acute obstructive appendicitis. Thrombosis of appendicular artery causes ischemic necrosis of full thickness of the wall of appendix, gangrene of appendix, perforation of the tip of the or the base causes perforation peritonitis. After perforation, localized by the greater momentum and dilated ileum occurs with suppuration and pus inside, forming appendicular abscess. In severe acute appendicitis, localization can occur by momentum and dilated ileum without pus inside, forming appendicular lump or appendicular mass. Acute appendicitis with blockage of opening of the lumen, inflammation, lumen cause inflammation rarely subside, and mucus collect inside the lumen of the appendix, resulting in its enlargement called mucosal of appendix. So these are all actually the mainly these are all complications of appendicitis, like appendicular lump, appendicular abscess, and appendicular perforation, and appendicular mucosal of appendix. These are all complications of acute appendicitis. Appendicitis pathogenesis and clinical findings. Picture showing obstruction of appendicular lumen by Fecoli, fibrosis, neoplasia, foreign body, or lymph node in kids, causes appendix distension and spasm. It may convert to stretching of visceral peritoneum, stimulation of autonomic nerves T9, T10, causes progression of inflammation over several days, variable length of time, causes irritation of peritoneum, parietal peritoneum, stimulation of somatic vessels, or appendix distension and spasm, increased lumen pressure, decreased flow to appendix, blood flow, ischemia of tissue, necrosis, loss of appendix structure integrity, bacterial invasion of appendix wall causing transmural inflammation and necrosis, which cause irritation of parietal peritoneum, or it may be perforation of colon wall causing peritonitis abscess of death. It causes stretching of visceral peritoneum, stimulation of autonomic nerves causing dull, crampy, diffuse periumbilical pain. It may develop fever, diarrhea, constipation, vomiting, or anorexia as inflammation worsens. Irritation of parietal peritoneum and stimulation of somatic nerve, focal, intense, persistent right lumbar or right iliac fossa pain, abdominal gardening, and peritoneal signs like percussion and rebound tenderness. Types of acute appendicitis. Acute non-obstructive appendicitis is called catarrhal. Inflammation of mucous membrane occurs with redness, edema, and hemorrhage, which may go for following course. It may be resolved or ulceration, or maybe fibrose or suppurate, or may cause recurrent appendicitis, or may gangrene and causes peritonitis. May gangrene and cause perforation and peritonitis. Acute obstructive appendicitis, it first collect in blocked lumen of appendix, which is blackish, gangrenous, edematous, rapidly progressive, leading to perforation either at tip or at the base of appendix. This leads to peritonitis. Formation of appendicular abscess or pelvic abscess. The third category of appendicitis is recurrent appendicitis. Repeated attack of non-obstructive appendicitis lead to fibrosis, adhesions causing recurrent appendicitis. It may cause subacute appendicitis, milder form of appendicitis, or fifth form of stump appendicitis is the stump appendicitis. It is retained long stump of appendix, often commonly after laparoscopic appendicectomy. Stump appendicitis occurs. So these are 5 types of appendicitis: acute non-obstructive, acute obstructive, recurrent appendicitis, subacute appendicitis, stump appendicitis. Now come on the clinical features, very important, everybody must know. It is rare before the age of 2, common in children and other age groups. First symptoms is the pain. Earliest symptoms, visceral pain start around the umbilicus due to distension of appendix. Somatic pains occur at right iliac fossa due to irritation of parietal peritoneum due to inflamed appendix. Pain eventually severe and diffuse, which signify spread of infection into the general peritoneal cavity. This picture showing visceral and somatic pain. This innervation of parietal peritoneum, intercostal nerve, and skin pain is very important. It causes pain in appendicitis. First, pain starts at the umbilicus and goes into the right iliac fossa. Second important symptom is the vomiting due to reflex pylori spasm. Third, constipation or diarrhea can occur if appendix is post-ileal or pelvic position. Next symptoms is the fever, tachycardia, fetor oris. Then it may cause urinary frequency due to bladder irritation. Signs of tenderness and rebound tenderness like McBurney spine in right iliac fossa. Revise sign, or we can say lumbar sign, are typical. These are pictures showing acute appendicitis symptoms: pain in right iliac fossa, fever, anorexia, nausea, and vomiting. These three Murphy's pride: pain, fever, and nausea and vomiting. This is called Murphy's pride. It's very important. Everybody must know if patient have pain in right iliac fossa with fever and anorexia and nausea and vomiting. This is the features of acute appendicitis. This is called Murphy's pride. This picture also showing appendicitis, inflamed appendix. Patient has a fever, nausea, vomiting, right? Lower quadrant pain, McBurney spine, tenderness at McBurney spine. Inflamed appendix causes increased pressure, gut flora multiplies, E. coli and bacteria, decrease immune system, increase white cell count. This is very important picture. So it's showing right lower quadrant pain, McBurney spine, pain at the McBurney spine, fever, nausea and vomiting, and also showing uh, pathology, appendicitis, inflamed appendix, increased pressure, increased gut flora in a patient of decreased immunity, increased WBC count. Closing sign. On pressure on the left iliac fossa, pain occurs in the right iliac fossa, which is due to shift of bowel loop, which irritate the parietal peritoneum is called closing sign. It is very important. Next is the hyperextension in case of retrocecal appendix, Pope's toes test, or internal rotation in case of pelvic appendix, obturator test of right iliac, right hip cause pain in right iliac fossa due to irritation of psoas muscle and obturator internus muscle respectively. So these are also very important. You must know what are the lumbar sign, what is the losing sign. Rebound tenderness is called lumbar sign. Losing sign is the where we press on the left iliac fossa, pain on the right iliac fossa. This is a losing sign. Hyperintensity extension like Pope's test and obturator test. This picture showing elicitation of source and obturator signs. Pain elicited by either source or obturator minors suggests an irritation of respective muscles by an inflammatory process such as acute appendicitis or a rupture appendix or pelvic inflammatory disease. Now come on the Belling's test positive in retrocecal appendix when legs are lifted off back with the knee extended. The patient complains pain while pressing over the flank. For rectal examination, tenderness in right side of the rectum is the it can be the clinical features. Hyperesthesia in Siren's triangle is the can be a clinical feature of acute appendicitis. This picture showing Siren's triangle, spinoumbilical line, McBurney spine, anterior superiliac spine. Siren's triangle formed by the pubic symphysis, umbilicus, and anterior superiliac spine. A triangle is made. So this picture showing McBurney spine and Siren's triangle. McBurney spine is also very important. We elicit tenderness and profound tenderness at McBurney spine, and we also make incision at McBurney spine, gridiron incision, and by the appendicectomy. So, and tenderness we elicit on the Siren's triangle with dry line at umbilical to the pubic symphysis, and third on the dry line on the anterior superiliac spine. McBurney incision we give on the incision a line draw from umbilicus to the anterior superior spine, iliac spine. Middle two-third and anterior one-third is the point where McBurney spine is present. So this is all about McBurney spine is Siren's triangle. Clinical signs in appendicitis, Rosin sign, lumbar signs, we call release sign, source test, obturator says, Belving sign, rested signs, comfy cuff tenderness. It is also very important. Patient lie when it cough, he has tenderness on right hip fossa. Buffet bed shaking test, heel drop test. These are all clinical signs in appendicitis. Now come on the appendicitis in infancy, rare, 80% chances of perforation with high mortality, at 50%. Acute appendicitis in children, localization is not present, and also peritoneal occur very early. It require early surgery. Dehydration, septicemia is very common. So in children, early surgery is mandatory. In elderly, gangrene and perforation are common because of lax abdomen wall. Localization is poor, so peritonitis sits in early. In pregnancy, appendix shift to upper abdomen, so pain is higher and more lateral. Appendicitis is most common non-gynecological surgical emergency during pregnancy. Incidence of perforation is highest in third trimester. Surgery is the treatment. Fetal death rate is 5%. Differential diagnosis of acute appendicitis, very important. Many conditions mimic acute appendicitis, is different in adult, elderly, and female. Perforated duodenal ulcer, fluid trickles down along right paracolic gutter and mimic appendicitis. So, one of the differential diagnosis of acute appendicitis is the perforated duodenal ulcer. Second is acute cholecystitis, may mimic acute appendicitis. Pain in right iliac abdomen, fever, and jaundice can occur in acute cholecystitis, but may not be present. Abdominal curling are features. Ultrasound, HIDA scan, LFT will differentiate it from acute appendicitis. Acute pancreatitis can also mimic acute appendicitis. Pain in epigastrium, radiating to back, raised serum amylase and lipase. CT abdomen with history of alcohol intake are the diagnostic of the acute pancreatitis. Right ureteric colic also may present as acute appendicitis. Pain in colicky nature, which often refer to genitis, hematuria, urinary symptoms are common. It mimics retrocecal or pelvic acute appendicitis. In ureteric stone, abdomen is soft and non-tender. CT is the important way to differentiate acute appendicitis from the ureteric stone. Acute typhlitis, inflammation of cecum. Intravenous or oral metronidazole completely controls the disease. Acute typhlitis. Acute bacterial enterocolitis present with pain in abdomen, diarrhea, toxemia, and dehydration. So, this is also one of the differential diagnosis of acute appendicitis. So, these are a few: perforation duodenal ulcer, acute cholecystitis, acute pancreatitis, ureteric stone, typhlitis, bacterial enterocolitis, acute mesenteric lymphadenitis is also one of the differential diagnosis of appendicitis. It's difficult to differentiate from acute appendicitis. It is treated conservatively. CT scan may be the helpful. Laparoscopic evaluation is ideal. Right side acute pyelonephritis is also represented as acute appendicitis, pain and tenderness in loin, urine analysis, ultrasonography is the diagnostic, and DTP scan may be needed. Crohn's disease with acute symptoms will have a similar features of acute appendicitis. Pelvic inflammatory disease like sulfonylureas may mimic acute appendicitis. Twistage, hemorrhagic rupture ovarian cyst, rupture ectopic gestation, endometritis, tubulovarian abscess mimic acute appendicitis in female. Ultrasonography, laparoscopy help to differentiate it. Midle's tumors is the lower abdominal pain due to rupture of follicular cyst during mid-cycle is the one of the differential diagnosis. It subsides on its own. Intussusception mimic acute appendicitis in children. Intussusception is common before the age of 2 years, but acute appendicitis is there with the age of 2, below the age of 2. Palpable mass, features of intestinal obstruction, barium enema, X-ray, ultrasound are useful methods to differentiate intussusception. Worm infestation is also important differential diagnosis. Present as a pain in right iliac fossa. May be One manifestation may have a feature of intestinal obstruction. Right side lobar pneumonia and pleurisy, pleural rub present in the pleurisy, and right side is pneumonia. Chest X-ray can identify pneumonia. Testicular torsion and acute severe arthritis, deferred pain in right iliac fossa. The scrotum is not palpated clinically, can be mistaken for acute appendicitis. Much more obvious if testis is undescended. One, carcinoma cecum, sigmoid diverticulitis in elderly with loop lying toward right iliac fossa may present as a pain in right iliac fossa. Rupture, aortic aneurysm, acute intestinal obstruction, and mesenteric ischemia may present like acute appendicitis. Rare condition like prehepatic pain of right 10th and 11th ribs, dorsal nerve may mimic acute appendicitis. There will be significant hyperesthesia. Tabes crisis, tuberculosis of spine, secondaries in spine, multiple myeloma, osteoporotic pain often can mimic acute appendicitis. Acute crisis of porphyria, diabetes mellitus mimic acute appendicitis with severe abdominal pain. Differential diagnosis in children, especially in children, are Meckel's diverticulitis, acute colitis, acute ileal lymphadenitis, acute succussion, roundworm, colic, lobar pneumonia. These are all differential diagnosis in children. Differential diagnosis in female, rupture ectopic gestation, mitral से MERS, rupture of ovarian follicle during menstrual cycle, ovarian cyst or torsion, salpingo-oophorytis it is a TD in female. Differential diagnosis in elderly patient, acute diverticulitis, carcinoma, cecum, acute features, mesenteric ischemia, intestinal obstruction, aortic aneurysm, leak, and Crohn's disease is the clinical differential diagnosis of acute appendicitis in children and elderly patient. Now come on the sequelae of acute appendicitis. Very important. It can be resorption. It can release and recurrent appendicitis. Relapse and recurrent. It can form appendicular mass or it can form appendicular abscess. It can be perforated to form perforation of appendicitis, perforation peritonitis. Has got 20% mortality. Peritonitis can cause total pyemia. These are all sequelae of acute appendicitis. Now come on the investigations of acute appendicitis. First, total leukocyte count it increase. Second, ultrasound to rule out other cause of conditions like ureteric stone, pancreatitis, ovarian cyst, ectopic pregnancy, and also to confirm appendicular mass or abscess. Laparoscopy is the useful method for the to investigate acute appendicitis. Sonographic criteria for appendicitis: 85% specificity, non-compressible appendix of size more than 6 mm, anterior-posterior diameter, hypoechoic thickness, appendix wall more than 2 mm, target sign, appendicolith, interruption of submucosal continuity, periappendicular fluid is the criteria for sonography. This is showing sonographic picture of acute appendicitis. Is showing thickness of and anterior is showing anterior posterior diameter and thickness of appendicular wall, appendicle wall also. Next investigations is the contrast CT scan. It's very much useful, especially in old people. Shows dilated appendix, dilated lumen, thickened wall, non-filling of lumen by contrast or air, periappendicular fluid collection, presence of mass, abscess associated pathology like carcinoma can be identified by the CT scan. It has 95% sensitivity and specificity with 95% accuracy. So it is very important investigations for the, especially in the elderly patient. So contrast CT scan when doubt should be done. C-reactive protein non-specific increase in acute phase 99M technician HMPO labeled leukocyte imaging may guidance in deciding management. Brain X-ray may show lumbar scoliosis to the right due to source spasm, obliteration of pre-peritoneal fat line due to retrocecal appendicitis, speckled extraluminal gas in right iliac fossa, gas in appendix, and pneumoperitoneum when perforate. This is showing X-ray showing appendix. Now come on the Alvarado scoring of for the appendicitis. When facilities of scanning imaging technology was not available, it's also important today to actually confirm diagnosis, confirm, we can say there are various scoring system available to decide. Alberto scoring is very important for the appendicitis. It is 10 total 10 score like migrating pain 1, anorexia 1, nausea and vomiting 1, tenderness in right iliac fossa 2, rebound tenderness 1, elevated temperature 1, leukocytosis with count more than 10,000. If it is more than 20,000 means there is abscess. Shift to late with neutrophilia and peripheral smear. Total score 10, score less than 5 not sure, score between 5 to 6 compatible, score between 6 to 9 probable, score more than 9 confirmed. Other scoring system, Kalam's modified Alvarado scoring system where shift to left is removed. Janki's scoring system, abdominal tenderness 4, rebound tenderness 3, total count more than 1200 per cubic millimeter of blood, USG feature 6. So these are one Ripasa scoring system 15 parameters, Anderson is scoring system at parallel. Now come on the treatment. Treatment is the surgery. It is called appendicectomy. Approach, various approach like gridiron, Rutherford Morrison incision, lens incision, right lower pyramidine incision, lower midline incision, laparoscopic approach, follows where approach by cutting muscles medially over the rectus. So these are all various approach. Grid iron incision or McBurney incision, which is very common. We have done incision place perpendicular to the right sternal-umbilical line at McBurney spine. That is at the junction of lateral 1/3 and medial 2/3 of the spinal-umbilical line. Grid iron is the frame of cross beam to support a ship. Second is the Rutherford Morrison is muscle cutting incision. Muscle are cut upward and laterally. Less squeeze incisions centering at McBurney spine. It is cosmetically better. Otherwise, internal exploration is same. Right lower pyramidal incision, lower midline incision when in doubt or when there is a diffuse peritonitis, we do mainly lower midline incision. Laparoscopic approach is becoming popular and better, and polar wares approach by cutting muscle medially for the rectus. This picture showing incision for open appendicectomy. This is McBurney spine at spinal umbilical line. The line draw on from the spine umbilicus to the superior spine. Lateral 1/3 and 2 at the point of lateral 1/3 and medial 2/3. there is a grade in Meghbani spine. Where is do gridiron incision. Lens incision is the point. It is a transverse incision basically. Blue line showing lower midline incision. Below the umbilicus, we do a midline incision in case of perforation or in case of perforation peritonitis by the appendicular perforation. Procedure we generally do under general anesthesia or spinal anesthesia. The skin is incised. 2 layer of superficial fascia, scarpa fascia and fascia, Kemper fascia. We cut Kemper fascia first and then scarpa. External oblique neurosis is open in the line of their incision. Internal oblique and transverse muscles are split in line of their fiber. Peritoneum is open in line of incision. Cecum is identified by tinea and ileocecal junction. Omentum when adherent is separated. Appendix is held with Pepper's forces. Mesoappendix with appendicular artery is ligated using thread or silk. A persistent suture is placed around the base of appendix. It is not very common nowadays. Base of appendix is crushed with artery, forceps and transfixed using vicryl, absorbable suture. Appendix is cut distal to suture and ligature and remove the suture or ligature and remove. Stump is cleaned with antiseptic betadine solution. Persisting suture is tightened so as to bury the stump. In difficult case, retrograde appendicectomy can be done. In presence of pus or burst appendix, the peritoneal cavity is drained. Then we place a wash when we place a drain. This picture showing steps of appendicectomy. This picture showing ligation of appendix, cut of appendix. This is the appendix cut section. This is the specimen of appendix. This picture showing laparoscopic appendicectomy. We put 3 port. If the first port is the infraumbilical region and 2 port at the below the umbilicus around the rectus abdominis muscle is showing umbilical port to 10 mm port to 5 mm port. Monitor present on the head of the patient and surgeon on the left side of the patient, left side of the patient. Complications of after appendicectomy, main is the paralytic ileus. Second, reactionary hemorrhage due to slipping of ligature of the appendicular artery. Residual abscess, pelvic or paracolic local subdiaphragmatic abscess. Portal pyemia, adhesions, kinking of intestine obstruction, kinking and intestinal obstruction. And right inguinal hernia, fecal fistula, wound sepsis, respiratory distress, respiratory problem, and deep vein thrombosis. Now come on the incidental appendicectomy. Here removal of normal appendix is done at laparotomy. For other condition, that is for hysterectomy, done in vague lower abdominal pain of doubtful severity. It is useful procedure to tackle Munchausen's syndrome, that is the patient is always worried of pain, abdomen and get relief after the procedure. Psychological benefit. It is done along with Let's procedure for malrotation. It is also done breathing on table colonic lavage It is not done in Crohn's disease during acute phase of appendicitis, post irradiation or immunosuppression patient. Now come on the appendicular mass. What is appendicular mass? These are all complications of appendicular mass, appendicular abscess, appendicular perforation. These are all actually these are all complications of acute appendicitis. First, appendicular mass, localization of infection 3 to 5 days after an attack of acute appendicitis. Inflamed appendix, greater momentum, edematous cecum, parietal peritoneum, and dilated ileum forms a mass in right iliac fossa. Tender, smooth, firm, or well localized, not moving with respiration, not mobile, resonant on percussion. Investigations, total count, and ultrasound to perform diagnosis. Treatment is conservative. Ashner Sirhan's regime. We give antibiotic and patient NBM. This picture showing appendicular mass is greater momentum, appendix, inflamed appendix, dilated ileum. They form a mass on the right iliac fossa. Second complications is the appendicular abscess occurs due to suppression of acute appendicitis, commonly occur in a retrocecal region. High fever, features of toxicity, tender, smooth, dull on percussion. Ultrasound, confirmed diagnosis. Treatment is antibiotic, CT guided aspiration or catheter drainage, percutaneous drainage, pelvic abscess is drained perrectally or posterior colpotomy in female patient. Interval appendectomy after 3 months. Thank you so much. That's all for today. जीवन जीवन इसको बोला ना विपुल 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 बोला देना
तो वो कुछ बोल रहे थे कि सर से बात हुई थी कुछ पहुंचाने का। सर
पहुंचा तो दिए, 2 पहुंचा के मैं बात कर लूँगा। मैं क्या बोलना था ना कि सर हाँ क्लास है। हाँ बिल्कुल, उसको सेव कर लो।